So welcome to today's presentation on irritable bowel syndrome and related conditions. We're going to be discussing updated treatment recommendations, therapeutic advances, and managed care considerations. Dr. Cash and I will be sharing the stage today. He is Chief from Gastroenterology, Hepatology, and Nutrition at Dan and Lily Sterling Professor of Medicine at the University of Texas Health Science Center at Houston. And I'm Catherine Cook. I'm a Research Associate Professor at the University of Maryland School of Pharmacy. Here are our disclosures. This program is provided by HMP Education, an HMP global company, and it's supported by an independent educational grant from AbbVie Incorporated and Ironwood Pharmaceuticals. So we have 4 learning objectives today. Describe irritable bowel syndrome and associated subtypes conditions, including irritable bowel syndrome with constipation, IBS-C, IBS-D is with diarrhea, IBS-M is mixed symptoms, IBS-U is unsubtype, CIC is chronic idiopathic constipation, and OIC is opioid-induced constipations. So we'll be talking about those disease states in terms of the epidemiology, disease burden, pathophysiology, and diagnosis. We're going to evaluate the clinical data and mechanisms of action associated with newer and emerging agents for the treatment of IBS and related conditions, including CIC and OIC. And we're going to develop strategies to improve the provision of guideline-directed care and clinical practice for the optimal diagnosis and management of IBS and related conditions, including CIC and OIC. And lastly, implement cost-effective and evidence-based managed care policies to improve patient outcomes and minimize the burden of IBS and related conditions, including CIC and OIC. So our agenda today, I'll be starting off the program with an overview of irritable bowel syndrome. Dr. Cash will come in the middle, talking about the clinical presentation and management of IBS, and then I'll return to discuss managed care considerations, and then we will open it up for your questions at the end. So first section, overview of irritable bowel syndrome. So irritable bowel syndrome, or IBS, is really a heterogeneous disorder characterized by recurrent abdominal pain, and that's a key criterion that Dr. Cash will talk about, as well as disordered defecation. It's fairly common. As you see on the right-hand side, IBS affects about 1 in 20 people in the United States. It was previously called functional gastrointestinal disorder. It was lumped into that larger group of disorders. It's now referred to as gut-brain interaction. And really the reason why is because there was kind of an inability to find something, physiologically different in, or anatomically different in the gut. And so now that we have a better understanding of the pathophysiology, it's linked to kind of gut-brain interactions. And also there was some stigma associated with the disorder that prevented people from really getting treatment, getting care, and improving the quality of life with this disorder. Just a couple of facts in terms of IBS epidemiology. It's more common in women and those who are younger than 50 years. Here we kind of look at, just to kind of give you a perspective on who's accessing care for IBS or chronic abdominal pain. So this was a study done with National Ambulatory Medical Care Survey. 2007 to 2015 was the time frame, and it evaluated 1,181 ambulatory care visits per 100 U.S. population. In other words, that was how common it was. So about 1,000 per 100,000 population. And if you look at the table on the right-hand side, you can see that the groups of age where there's more office visits are 40 to 59 is about 37%, and then 60 to 79 is about 34%. It trails off over 80, and it is less common in those 18 to 39 years old, although again, still 20% of visits. As I mentioned on the first slide, it's more common in the female population, so about 2/3 of visits were by females. More common in women in terms of, or race in terms of white, 83%. Black was a 9.6, and then other was 7.2. This study didn't look at all comorbidities of patients, but looked at a few select ones. Depression being the most common, about 15.5% of patients who had these ambulatory care visits also had comorbid depression, diabetes at 13%, and obesity at 9%. So when we kind of think, we talked about a heterogeneous group of disorders, right? And we talked a little bit about the subtypes on the objective slide. So IBS-C, constipation, IBS-D, diarrhea. And so this is the predominant, gastrointestinal complaint, constipation, IBS-C, whereas diarrhea is the predominant complaint with IBS-D. Mixed is obviously a combination of them, and an unsubtyped is where there isn't a clear-cut picture of one of the other subtypes. When I'm looking at epidemiologic evidence, some reported about a quarter in each one of these, some reported higher percentage with IBS-D. Part of the challenge is in figuring out who is seeking care, right? So if more individuals seek care, it might not mean that the disorder is more prevalent, but that it appears more in terms of healthcare utilization. I think the key aspect to walk away with is that more than half of patients with IBS actually changed the predominant subtype over a 1-year period. So again, we'll see kind of as we understand more about the pathophysiology, you're not necessarily in one of these boxes for the entirety of your IBS kind of symptomatology. So just something to think about as we look at the evidence and the drug therapy. Here's some more information kind of about looking at these subtypes by sex. And you can see here, so the kind of darker blue, maybe purple, it shows women, and then the lighter blue shows men. And so among women, IBS-C, constipation, is more common. Among men, you can see the IBS with diarrhea is more common. It's fairly equivalent in IBS mixed and IBS unsubtype, but you can see the diarrhea more common in men and the constipation more common in women. We also talked a little bit about with that ambulatory care survey about the mental health of patients with IBS, and certainly many patients with IBS report psychological distress. Those that do report higher levels of stress have higher and more severe levels of GI symptoms. So in this study, we can see fatigue was 60%, anxiety a close second at 56%, depression and stress were about 38-39% of patients in this study. So very common mental health concerns in patients with IBS. And we'll find out as we kind of talk about caring for patients that it's important to address not only the mental health in addition to the physical health of patients with IBS. Here's a study that looked at mental health and quality of life. And so individuals, the schematic shows that 161 individuals were considered positive using the Rome 3 criteria for IBS. And then over time, about a third of them, 30%, became negative at follow-up. So 49 patients, about 30% became negative. What they found in this study, however, was that despite the improvement in symptoms, there was not a significant improvement in quality of life. And that general anxiety and depression, work absenteeism, productivity, life satisfaction were comparable. So they didn't, even though patients had improved GI symptomatology, they didn't see a correlation with the improvement in quality of life that was significant, and still many of the psychological alterations persisted. So again, very important to consider both of these aspects when we're talking about patients. Here's a survey I think that provides a little bit more insight into people's experiences, those that have IBS. I think not on this slide, but something I want to point out is less than 1% of patients with either IBS-C, constipation, or IBS-D, diarrhea, reported that they were not bothered by their symptoms. So 99% plus are bothered by their symptoms. This survey had 3,200 respondents, about an equal mix with those with constipation and those with diarrhea. The demographics were similar to what we talked about earlier, 81% female, 90% Caucasian, and the mean age was about 47 years. The majority and the most common symptom was actually abdominal pain within the past years, and pretty high for most of those patients. So 84 and 93% in the two subtypes. And about half said that these symptoms were extremely bothersome in both the constipation and diarrhea group. So when we kind of look at what the impacts are in people living with IBS, the next slide really shows us kind of how IBS interferes with activities. So on the left-hand side, it says, because of symptoms I have avoided. So avoided situation where there was no bathroom, and that's the far 81% of those with diarrhea avoided situations where there's no bathroom. There's also between 50 and 60 or 50 and 70% avoided making plans, leaving the house, or sex, regardless of the IBS subtype. And then on the right-hand side, it said my symptoms prevented me from Again, between kind of 50 and 70% enjoying daily activities, traveling more, and then reaching my full potential, being successful. And a quote kind of from, another aspect that patients reported is that over half of the patients with IBS said that their symptoms make them feel not normal, not like themselves, or self-conscious. So again, this disease has a large impact on quality of life, activities of living. So important to think about the physical and mental health aspects as we look to improving care. So I'll now turn it over to Dr. Cash for his clinical presentation.
Hello, I'm Brooks Cash. I'm Chief of Gastroenterology and a Professor of Medicine at the University of Texas Health Science Center in Houston, Texas at the Texas Medical Center. It's my pleasure to be able to talk to you today about irritable bowel syndrome and related conditions. I'm going to update you on treatment recommendations, therapeutic advances, and we're also going to be talking about managed care considerations in this program. So it's important to understand the impact of irritable bowel syndrome. And the primary impact of irritable bowel syndrome is on our patients in terms of their quality of life, but there's also a societal impact. There's increased healthcare resource utilization, and there's increased absenteeism and presenteeism. It impacts patients' social lives as well as their work lives, and that in turn can lead to significant increased costs. So there's been a lot of data and studies that have been done. I'm going to throw three blurbs out here. In terms of impaired health status related to irritable bowel syndrome, it's been found to actually restrict an average of 73 days of activity per year in one study that was done. Up to nearly 40% of patients with IBS report having contemplated suicide as a result of their GI symptoms. And in another study, there's an average of 1.5 missed days of school or work and 8 days of lost productivity. That can be being present and being less productive, what we call presenteeism, or absent in another study. So significant costs associated with irritable bowel syndrome. The other issue, one of the other issues with regards to IBS is that it often remains undiagnosed, and this leads to the increased healthcare resource utilization as patients go from doctor to doctor, clinician to clinician, looking for an answer for their chronic gastrointestinal symptoms. This is the 7th most common diagnosis that's made by primary care providers, so we know about it, we're familiar with it, but on average, we see patients suffer for about 4 years before they're ever diagnosed. 2/3 of them have their symptoms for at least a year before even seeing a healthcare provider, and at the end of the day, only about 25% of patients are formally diagnosed based on clinical criteria. Now, the pathophysiology of IBS is very complex. This slide depicts some of the things that we've recognized over the last 4 decades or so, and it's not simply that it's a psychosomatic type of disorder. We do know that psychological stressors can augment symptoms, but we've recognized that there's much more of an organic basis for IBS symptoms, whether it's microinflammation or post-infectious immune-mediated changes, dietary intolerances with regards to different enzymes or deficiencies in digestion, impaired gut barrier function, altered microbiota, or alterations in the enteric nervous system. So we've recognized these changes. The problem is we can't readily diagnose these changes, and we don't know whether some of the therapeutic approaches that we use are going to reverse these changes. We don't know whether it's cause or effect. But there is an organic basis to IBS, but it's a multifactorial organic basis. And that's highlighted in this slide, which is the biopsychosocial conceptual model of the IBS journey. You can see the psychological factors here. There's also physiologic factors. There may be genetic components leading to alterations in the gut-brain axis, the generation of the typical IBS symptoms, which is abdominal pain associated with altered bowel habits. And that leads to healthcare resource utilization, decrements in daily functioning and quality of life, and ultimately increase in cost to our patients as well as society. So let's talk about how we diagnose IBS. We use what are called the Rome criteria. I'm showing you the Rome 4 criteria, which are the current criteria in place. To have IBS, patients should have recurrent abdominal pain on average at least 1 day per week in the past 3 months associated with at least 2 of those features that you see there. The pain should be related to defecation or it should be associated with a change in the form of the stool or a change in the frequency of the stool. Some patients will have all 3 of these features. The central tenet, though, for IBS is abdominal pain and an association with altered bowel habits. Now, there are different subtypes of IBS. There's IBS with diarrhea, there's IBS with constipation, and there's patients who have a mixture of both constipation and diarrhea. We define those subtypes based on the stool form as well as the frequency with which they have that predominant stool form. So for instance, patients with IBS with constipation will have a type 1 or type 2 stool form at least 25% of the time, and they will have diarrhea, a type 6 or 7 stool form, less than 25% of the time. Conversely, somebody with IBS and diarrhea will have diarrhea at least 25% of the time, type 6 or type 7 stool, and constipation less than 25% of the time. And then the mixed group have both stool forms at least 25% of the time. The other thing that this slide differentiates is IBS from functional or chronic idiopathic constipation and functional diarrhea. For those diagnoses, patients don't complain much about abdominal pain. For IBS with diarrhea or constipation or mixed, abdominal pain is central to that definition, and it is a symptom-based definition for these conditions. So making a positive diagnosis is important. Here's 5 key features to that diagnosis. Number 1, take a careful history. Number 2, perform a physical exam. Make sure that patients don't have abdominal masses or any other abnormalities. We want to apply symptom-based criteria, such as the Rome 4 criteria, assess for alarm features, and then classify the patient according to their IBS subtype, as that will then dictate how we treat those patients. So just in terms of a few words on physical examination, this is important to do. We want to get an idea of the history of the patient's symptoms, the chronicity, any triggers, what their diet is there a family history of organic gastrointestinal diseases? Do they have any comorbid conditions such as fibromyalgia, migraine headaches, or cystitis type symptoms? And then we want to do that physical exam. The things that we really want to rule out are any masses or abnormalities. In the case of constipation, it's very important to do a digital rectal examination to assess for pelvic floor dysfunction. And don't forget about chronic abdominal wall pain. That can be elicited with a very simple test called a Carnet's test, and that can be a frequent masquerader of these patients' symptoms. So this is very important to do. It's critical and part of the diagnostic process. Now, I mentioned alarm features, and these are features that should make us think more about organic gastrointestinal diseases. And this is not an all-inclusive list, but if you uncover some of these historical features, such as a family history of colon cancer or celiac disease or inflammatory bowel disease, new symptoms in an older patient, unintentional weight loss, fever, hematochezia, recent travel, new medications, these are things that should make us think we need to do a more thorough or more extensive diagnostic evaluation. They are pointing more towards an organic etiology and especially a new onset etiology of symptoms. Now, a lot of patients won't endorse these alarm features. And if you make those, if somebody fits those Rome 4 criteria and they don't have alarm features, then you can feel quite confident that your diagnosis of irritable bowel syndrome based on their stool form is an accurate diagnosis. There are some laboratory tests and evaluations that we do recommend, and that's shown on this slide. So it is recommended that everybody who's being evaluated for irritable bowel syndrome, if they've never been evaluated before, get a CBC, because anemia is one of the alarm features. So for the very pragmatic reason that we want to rule out anemia. It's also recommended that if somebody is over the age of 45, if they're average risk and they've never been screened for colon cancer, then we ought to screen them for colon cancer. The risk of colon cancer in patients with IBS is actually lower than it is in the general population, probably because they get more colonoscopies and evaluations. However, it is important to screen for colon cancer. So if somebody's over the age of 45 and they've not been screened, these types of symptoms can provide an entry into achieving that screening. Now, we generally recommend more diagnostic tests for patients with diarrhea because it's got a broader differential. So we look for inflammation with CRP or fecal calprotectin. We rule out celiac disease with a tissue transglutaminase. For the patient, we often will look for protozoa like Giardia, which can be one of the few chronic gastrointestinal infections. And we also should be thinking about bile acid diarrhea. We'll speak about that in a little while during my discussion. For irritable bowel syndrome with constipation, there's no specific tests. I generally do get a CMP specifically to look at calcium levels and make sure patients aren't hypercalcemic. And then when patients have severe or medically refractory symptoms, I will do some physiologic testing looking for pelvic floor disorders and disordered defecation, as well as slow transit. But those are later on in the evaluation of these patients. What about treatments? Let's start with treatments, and we'll start with over-the-counter therapies. This is an appropriate place to start in terms of treating patients with irritable bowel syndrome. And I'm going to start first with irritable bowel syndrome with constipation, because we have more of those therapies that are over-the-counter. The first one that's commonly recommended is fiber, and specifically soluble fiber. So this is going to be the psyllium-type fibers. This has been shown to be beneficial for patients with the symptom of constipation. And it's strongly recommended by the American College of Gastroenterology as a therapy for IBS with constipation. It's important to recognize that fiber's not been shown to improve the abdominal pain that's associated with irritable bowel syndrome. So while it can help patients' pain, clinical trial data just doesn't support that, but it can be an effective therapy for constipation. Similarly, osmotic laxatives such as polyethylene glycol, either used alone or in combination with fiber, can be helpful for patients with IBS-C as well. So it also does not or has not been shown to improve abdominal pain. So there's a little more of a tempered recommendation from the ACG against the use of osmotic laxatives for overall symptom improvement, specifically because that abdominal pain is not improved. It's absolutely appropriate and reasonable to use this medication, this over-the-counter therapy, for patients with IBS-C. We just want to have realistic expectations about what it may help in terms of those specific symptoms. And finally, stimulant laxatives are also available over the counter. These are typically irritant laxatives like Senna or Bisacodyl. The American College of Gastroenterology doesn't have any recommendations regarding the use of stimulant laxatives in IBS-C because these haven't been widely studied, but they can be effective therapies for some patients. So all of these therapies are very reasonable. Many times our patients will come to us, they've already tried these things before they come to see us. So what I'm showing you here is a slide of FDA-approved therapies for 3 chronic constipation syndromes, specifically IBS with constipation, opioid-induced constipation, and chronic idiopathic constipation. Now, I drew the comparison or the contrast with chronic idiopathic or functional constipation and IBS-C earlier. Remember, patients with functional constipation don't complain as much about abdominal pain, whereas it's central to the experience that IBS-C patients have. Patients with opioid-induced constipation are simply patients who start an opioid and then develop constipation. So when we consider these FDA-approved therapies, there's 3 secretagogues, and that's libiprostone, linaclotide, and plecanatide. The reason these agents are called secretagogues is they cause active secretion of fluid into the gut lumen. In the case of libiprostone, it's a type 2 chloride channel activator. Linaclotide and plecanatide are both agonists at what are called the GCC cyclase or guanylate cyclase C receptors, GCC receptors. These agents cause active secretion of fluid into the gut. They are indicated for both IBS-C as well as CIC, and in the case of libiprostone, an additional indication for OIC, because these agents have been studied formally in those populations, and the FDA has given approval based on those studies. And you can see the side effects or common adverse events with these agents, which is primarily going to be diarrhea, shown out to the right. We also have a prokinetic therapy in the form of prucalopride. This is a type 4 serotonin agonist. It increases colonic contractions. It is FDA approved for chronic idiopathic or functional constipation. And then finally, we have tenapanor, which is a newer agent. This is a sodium hydrogen exchanger type 3 inhibitor. It blocks or traps sodium in the gut lumen. It prevents sodium reabsorption. And in so doing, it keeps fluid in the gut lumen. So it's not causing active secretion, it's causing retention of fluid. And it's approved for the treatment of irritable bowel syndrome with constipation. I'll go walk you through some of the clinical trial results of these agents in a few minutes. So let's talk about lubiprostone first. This is one of the studies that was done for this agent for irritable bowel syndrome with constipation. Now, this is a very rigorous endpoint, so the response rates and the placebo rates look low. The important thing to note here is that the differences between lubiprostone and placebo were statistically significantly different in terms of improving overall IBS symptoms, and it appeared that it was a long-lasting therapy without a tachyphylaxis with continued use based on long-term data. Now, in terms of administration of lubiprostone, the dose for IBS with constipation is 8 micrograms twice a day. It's only approved for women because the study population was predominantly a female population. As I mentioned, it is also approved for OIC and CIC. The dose in that case is 24 micrograms twice a day in both men and women. It is recommended that patients take this medication with food because it can cause them nausea if taken on an empty stomach. Most common adverse events were nausea and diarrhea in the clinical trials, and it's a generally well-tolerated therapy. Now, if we move to the GCC agonist, we'll talk first about linaclotide. This is one of its primary or pivotal trial data results, and you can see about a 20% difference compared to placebo for what's called a FDA primary endpoint or a composite endpoint, which is at least a 30% improvement in abdominal pain. At the same time, patients had an increase by at least 1 complete spontaneous bowel movement per week for 6 out of 12 weeks. That is a bowel movement without the use of a laxative in which a patient feels completely evacuated. Now, the patients in these studies had on average about 0.1 to 0.3 complete spontaneous bowel movements per week. So if you did the math, that basically means they're having a complete spontaneous bowel movement about once every 10 to 12 weeks. So you can see that difference here, about a 33% response rate compared to about 14% with placebo. This was also statistically significantly different, favoring linaclotide for IBS-C. Now, if we look at the prescribing information for linaclotide, remember, it also is approved for CIC. There's two other doses for CIC. So the IBS-C dose is 290 micrograms once daily. The CIC dose is either 145 or 72 micrograms once daily. The primary adverse event that was seen in these clinical trials and in clinical practice is diarrhea. That's often self-limited and mild, but it can occur. So we do warn our patients about that. It is recommended that this agent be taken on an empty stomach and is only to be used in adults. Lubiprostone and the next therapy that we'll talk about, plecanatide, they share that characteristic. So if we do look at plecanatide, again, I'm showing you two trials here now for irritable bowel syndrome. The dose is 3 milligrams once daily, and we saw similar results. Remember, this is also a GCC agonist, so it is a very similar mechanism of action compared to linaclotide. The main difference being it's thought that plecanatide binds more avidly to this receptor at a lower pH, meaning more binding in the small intestine as opposed to the colon, whereas linaclotide is a bit more agnostic with regards to the pH and binding to the GCC receptor, so it's a whole gut agent in terms of its site of action. Regardless, we saw statistically significant differences favoring plecanatide compared to placebo for overall responders, which was a similar endpoint that was used in the linaclotide trials. Simultaneous improvement in pain and constipation symptoms. The dose here is 3 milligrams for either IBS-C or CIC. It's recommended to be taken with or without food. It is only to be used in adult patients, and the most common adverse event is diarrhea. Now, if we look at tenapanor, this is the latest entrant into the therapies for IBS with constipation. Remember, this is the agent that blocks sodium reabsorption, so it traps water in the gut. The dose for IBS-C that was studied in the pivotal trials, the Tempo 1 and Tempo 2 trials that I'm showing you here, is 50 milligrams twice daily. So that's the FDA-approved dose. All of these therapies that I've mentioned are non-absorbed or very poorly absorbed therapies. So they work in the gut lumen. And you can see for individual symptoms related to constipation as well as pain, and even when you combine those symptoms as a composite endpoint, that there are statistically significant benefits with tenapanor compared to placebo. The most common adverse event with tenapanor, again, is going to be diarrhea, similar to the other agents that we've talked about. It's only to be used in an adult population and should be taken immediately prior to the first meal of the day and dinner. So let's talk a little bit now on the other extreme. So we'll talk about IBS with diarrhea. And I tend to think of my therapeutic approach to these patients as being in major categories, kind of colluding towards or directed towards those different mechanisms that we think may be playing a role with diarrhea. So in no particular order, we use agents that may modulate the gut flora. That includes antibiotics as well as probiotics or even symbiotics or maybe even dietary changes. We talked about bile acid diarrhea. We can use bile acid binders. We use antispasmodics for pain, neuromodulators also for pain. And I'm going down below now. Opioid receptor modulators for patients with just simply diarrhea. These are agents such as diphenoxylate, eloxatiline, or loperamide. And then finally, anti-motility agents in the form of serotonin antagonists. And we'll talk a little bit about some of these therapies in the next few minutes. So we'll start with kind of the lifestyle, dietary, over-the-counter type therapy that we can use. And one of the most popular with regards to IBS and diarrhea is a low FODMAP diet. Now, FODMAP is a not terribly complicated acronym. It stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. I think of this as poorly digested sugars, carbohydrates, and fibers, or fructans. Fructans in particular, and you can see examples of those different foods shown on this slide. Fructans in particular seem to be some of the chief offenders for inciting GI symptoms. And the classic symptoms that we see with a high FODMAP diet are diarrhea, abdominal cramping, bloating especially, flatulence, gas, belching, distension. There are lots of theories as to why. And you can see in this somewhat complicated algorithm shown out on the right, some of the theories behind how FODMAPs may actually cause GI symptoms. Believe that the digestion not only by the human body, but also by our microbiota or bacterial colleagues in our gut, can lead to the production of short chain fatty acids and osmotically active agents, actually lower the pH of the gut, which can then lead to changes in fermentation and gas. And that, we believe, can actually change GI permeability and incite irritable bowel syndrome symptoms. Low FODMAP diets have been well studied in patients with irritable bowel syndrome and have been shown to be effective. Several important caveats that you absolutely need to recognize. This should be done with a skilled dietitian who knows how to administer and monitor the low FODMAP diet. We need to screen our patients who are contemplating for this therapy for avoidant and restrictive food intake disorders, because we can sometimes make things worse by putting somebody with an eating disorder or ARFID on a low FODMAP or restricted diet, or perhaps even a gluten-free diet. And then finally, this is not meant to be a perpetual diet. There is a reintroduction phase. It's actually a relatively short, significant restriction phase of about 6 to 8 weeks, and then we gradually reintroduce certain classes of foods. This is not meant to be a permanent thing, and I think that's often misunderstood. Let's talk about probiotics. Are these valuable or not? Well, generally, our GI societies would say no. In fact, the American Gastro Association recommends using probiotics only in the setting of clinical trials, and the American College of Gastroenterology recommends against the use of probiotics specifically for irritable bowel syndrome. There are a couple of very specific indications for probiotics. Infants with necrotizing enterocolitis would be one that the AGA endorses, but for irritable bowel syndrome, they do not have a significant enough evidence base for our societies to recommend their use. Antispasmodics are very commonly used therapies for irritable bowel syndrome, targeting abdominal pain. I want to highlight the use of peppermint oil. This is a non-prescription antispasmodic. It is primarily a calcium channel blocker. There are other potential benefits or mechanisms of action of peppermint oil. This has actually been relatively well studied, both in Europe as well as the United States. And I've included in this slide some data from a meta-analysis that shows that it's been demonstrated to improve global symptoms of IBS, as well as a study that we did looking at a specific triple-coated formulation that releases in the small bowel. If you are going to use peppermint oil for your patients, I tend to use it on an as-needed basis, and I only will allow or recommend my patients use enterically coated peppermint oil, because non-enterically coated peppermint oil can cause dyspepsia and worsen GERD symptoms. So it's important to get that into the small intestine before it's released. So enterically coated, and I use it on an as-needed basis. All right, let's talk about some of the FDA-approved therapies for IBS with diarrhea. We'll start with rifaximin. This is a non-absorbed or poorly absorbed antibiotic. We believe that it works by suppressing bacterial fermentation. It does not kill a lot of bacteria. It's primarily working on gram-negative therapies and gram-negative bacteria and inhibiting protein synthesis. It's been FDA approved for irritable bowel syndrome for now at least a decade. And there's some data that I'm showing you on this slide showing about a 10% difference with rifaximin compared to placebo for improving overall IBS symptoms as well as symptoms of bloating. It's a well-tolerated medication with minimal side effects and an adverse event profile that's very similar to placebo. Now, patients sometimes will get recurrent symptoms. It is appropriate in those patients, if they responded to an initial course, to retreat them with up to 2 additional courses. And that was proven in a retreatment trial called the Target 3 trial. You can see the adverse event profile here. It's very similar to placebo, well-tolerated therapy. The dose for IBS with diarrhea is different than the dose for rifaximin for other conditions that it is FDA approved for. For IBS with diarrhea, it's 550 milligrams 3 times a day for 14 days. Now, there's another therapy called eloxatiline. This is a mixed opioid receptor modulator. It works as an agonist and an antagonist at various opioid receptors. And it's thought that it decreases motility, but also helps improve abdominal pain. And there is clinical trial data that was convincing to the FDA. They approved this drug for IBS with diarrhea. You can see the changes here with 100 milligrams twice daily of eloxatiline compared to placebo for improving abdominal pain by at least 30%, as well as decreasing diarrhea and improving stool form. There are some adverse events that can occur. Constipation, the most common. It is recommended that you do not, and it's actually contraindicated to use this medication in patients who do not have a gallbladder who have a history of pancreatic disease or alcohol use disorder. So do recognize that. And I show that on this slide. The reason for that is there have been some cases of pancreatitis and sphincter voti spasm that have primarily occurred in patients with those risk factors. So the dose for elaxadiline is 100 milligrams twice a day. There is a lower dose that can be used in patients who, say, perhaps develop some mild constipation. You can go down to that lower dose, or you can use that lower dose in a specific subset of patients with certain risk factors, but do avoid this in patients who don't have a gallbladder or who have those other risk factors that are listed there. Bile acid sequestrants are another common thought or commonly employed therapy for IBS with diarrhea. And it's thought that bile acid diarrhea may account or may be present in up to 20 to 50%, 25 or 50% of patients with IBS with constipation. What we don't know is we don't know whether this is a true cause or effect phenomenon. Is it rapid transit that's causing poor bile acid reabsorption, or is it bile acids that's causing rapid transit, and thus we make this diagnosis? This can be a difficult diagnosis to make, and there's insufficient evidence right now with regards to identifying this as an etiology for IBS, and even less evidence in controlled trials showing that bile acid sequestrants are effective therapies for irritable bowel syndrome with diarrhea. Nevertheless, these are generally well-tolerated therapies. Again, they're luminally acting, and they can improve the symptom of diarrhea. And we've seen patients who do have an improvement in their IBS-D symptoms. It is important to recognize that you need to be cognizant of other therapies that patients may be using relative to the administration of bile acid sequestrants. This is an area of active research that we hope to see more data on in the future. Antidepressants are another mainstay of therapy for IBS. We tend to call these neuromodulators when we use these. We use these agents specifically for abdominal pain. Tricyclic antidepressants have the best level of evidence. SSRIs do not have much level of evidence at all, and I would recommend against that, as do our GI societies for patients with IBS. They tend to be agitating, and they've not been shown to improve pain. When we use tricyclic antidepressants, we use them in very low doses, such as dizipramine 10 or 25 milligrams at night before bed, so QHS dosing, and we titrate doses at monthly intervals and typically treat patients for at least 6 months. We also have some data on SNRIs for pain, but not as much as we have for the TCAs, but SNRIs may also be effective in some patients. But you have to take this on a case-by-case basis. Similarly, we can use psychological therapies for IBS. There's been a number of different therapies that have been studied quite widely. These center around things like cognitive behavioral therapy or reframing type therapies, gut-directed hypnotherapy, mindfulness meditation, even psychodynamic psychotherapy. The best, or at least the approaches with the most data, are gut-directed hypnotherapy and cognitive behavioral therapy. One of the limitations to these approaches has been the ability of skilled therapists in the US to be able to sit and spend the time with patients required for this form of therapy. However, there are now some web and app-based approaches and forms of these therapies that have been shown to be effective and similarly effective to in-person therapy. So that's an exciting arena for some of our patients. And I tend to use this for my patients who have persistent bothersome symptoms. They may get better, but they're still bothered by symptoms, and it helps them cope and manage those symptoms, and in some cases even suppress those symptoms when they do occur. So I want to conclude by reiterating that irritable bowel syndrome is not a specific disease. It's a syndrome of symptoms. It's a chronic functional disorder with no known cure and multiple different etiologies. There's no specific biomarker. The diagnosis is made in a positive fashion using clinical criteria through history and physical exam and judicious use of diagnostic tests. I went through a lot of the therapies that we have available for IBS, both over-the-counter, lifestyle modifications, as well as FDA-approved therapies, and hopefully that will help you interact with your patients. I think it's important for us to set realistic expectations for patients. We want to try to decrease the sine wave of their symptoms, the up and down, minimize those undulations, but it's not entirely unrealistic to think that there may be some chronic symptoms that patients will experience. It's important to use a multidisciplinary approach, bringing in your dietitian, screening for those avoidant and restrictive food intake disorders, perhaps having a psychology colleague have some input if patients are willing and have that insight. Employ shared decision-making with the patient as well. And of course, do feel free and encouraged to refer to a GI specialist for patients with severe and or refractory symptoms. So with that, I want to thank you, and I'm going to turn the program over back to Dr. Cook.
So thank you, Dr. Cash. So for this last section, we're going to kind of talk about managed care considerations and focus specifically on medication access and some considerations with the medications as well. So to first kind of understand the caring for patients with IBS, we kind of look at costs, right? Total direct costs. These are annual per patient costs. So patients with IBS, about $6,000 per patient per year. And then you can see the different subtypes. IBS-C was about $4,000. IBS-D was higher at $9,400. So I think the numbers are important, not necessarily to take home and memorize, but I think a couple of things to point out from this slide. One is that patients with IBS cost more than controls. So I think that makes sense. The second thing is that IBS with diarrhea costs more than IBS with constipation. So again, some aspects to think about. Why is IBS with diarrhea costing more? So let's look a little bit more into kind of what's directing those costs. We can see here, this is a distribution of annual all-cause healthcare costs for IBS-D diarrhea. And hospitalizations about 13.6% on the upper right-hand corner. Prescriptions, drug therapy was about 19.5%, and office visits and ED, emergency department visits, about 8%. However, the lion's share is kind of this big grouped category of other outpatient services. 50% of costs, annual all-cause healthcare costs, falls into that bucket. That's diagnostic tests, laboratory, radiology services. Part of the ongoing discussion with IBS is really kind of getting to a diagnosis quickly, because when patients kind of come in with symptoms and we're not finding any kind of specific, anatomic pathology, but there's a lot of tests, diagnostic lab or radiology otherwise that are going on to try to, rule out other causes. And so, a lot of work done with the gastroenterology community to try to ascertain, the appropriate ways to get to a diagnosis, and kind of especially in patients that don't have kind of cautionary or warning signs or symptoms. One of the large costs you can see here in the bullet point to the right is endoscopic costs, accounted for about 15.5% of symptom-related costs, and 23. So about 1 in 4, 1 in 5 patients are actually getting more than one endoscopy within a year. So again, important things to kind of think about as we consider caring for patients with IBS. The other thing that kind of just goes along with this, so that was costs. Healthcare resource use kind of goes along with the costs. And so we're seeing in patients with IBS diarrhea, significantly higher number of all-cause hospitalizations, ED visits, physician office visits, and then also monthly prescription fills. So I think this just aligns with the costs. The first slide just kind of explained how these different healthcare resource use was contributing to those costs, but they're all higher than kind of controls for IBS with diarrhea. The interesting aspect in IBS care is really kind of looking at disparities. And let me just orient you to this table. So we've got, these are differences in IBS care aspects or care metrics for patients that are Asian, Black, or Hispanic. And the difference is in percentage points versus white. So if it's a positive number, it means that these different communities, Asian, Black, Hispanic, had a higher use of that. And if it's a negative, they had a lower use of that measure or metric. So let's just start kind of with the lower use. Patients that were Asian, Black, or Hispanic had fewer GI consults. So they were cared, they were receiving less care by GI specialists than white counterparts. However, when we look at all the other parameters, we can see that they had higher number of IBS-related primary care visits. They received more GI procedures, and that including colonoscopy and esophagogastroduodenoscopy, or upper GI, as I like to say, procedures, right? And you can see many of them were statistically significant versus white patients. And so, part of the challenge here is it's very interesting when we look at disparities in care. They're getting more healthcare, but is that appropriate? And in some of the articles that I've read, it talks about maybe a mistrust between the patient and the provider, or a miscommunication, and so that they're more reliant on objective evidence than kind of maybe the discussions or the communication or the trust. And so one aspect that these studies have pointed to is really improving the use of shared decision-making. So what is shared decision-making? Shared decision-making is really helping to kind of figure out these different management strategies, which one is maybe best for your patient, right? Diet adjustment, eliminating exacerbating factors, therapies targeting kind of mind-body complex, so cognitive behavioral therapy, prescription therapies, which we heard a lot of Dr. Cash talking about the evidence, and over-the-counter therapies, which we heard some evidence there as well. And for these strategies, really kind of addressing care disparities when we consider all of them. So let's talk about shared decision-making for figuring out which management strategy is best for your patient. So what is shared decision-making? It's an informed, patient-centered discussion to assist with choosing IBS management. So on the left, we have 3 steps: introducing choice, describing options, and then helping patients explore preferences and make decisions. To ensure that shared decision-making is occurring, we need bi-directional communication. Sometimes decision aids may support shared decision-making. And then there's several factors to consider. And this list isn't all inclusive, but just to give an idea of factors that need to be incorporated in shared decision-making. So patients' personal beliefs, along with kind of drug-related factors, efficacy, effectiveness, tolerability, and safety, convenience, cost, duration of therapy. So all factors that are important to discuss when you're using shared decision-making and trying to come up with a strategy that's best for the patient. Here's an interesting study, pilot project. It was called Reduce IBS. This was available in an abstract only, so very limited information to kind of assess. But what they did is they provided patients with 10 handouts, and you can see on the left relating from broad information about IBS to specific elimination diet or antibiotics or peppermint oil, amitriptyline, citalopram. So different therapies. They had patients review those for 2 weeks, those handouts, and then come back and discuss with the GI physician and the nurse their top 3 most valued options. And then they treated the patients, after the discussion, they, agreed on those 3 chosen therapies and treated them sequentially for 2 months each, assessed symptoms and outcomes. And patients really appreciated the use of this shared decision-making and had improvements. Again, this was a pilot study that was abstract only. There was no control group, but they did report controls, historical controls. So you got to kind of take that with a grain of salt, but they felt 2 outcomes: reduced colonoscopy use, about 10%, and then reduced time for the GI physician by about 30 minutes. So again, something to just kind of illustrate the use of shared decision-making kind of in all the options for choosing therapy. When we think about kind of making those decisions related to medications, there's some aspects that come into play with medications. And we'll see through the next couple slides that the decisions kind of differ between the payer perspective and the patient's perspective. And so important to think about both of those. So when we look at economic assessments, let's just start with IBS constipation on the left-hand side. Patient perspective is on-label prescription drug therapy with linaclotide, least expensive. Payer perspective, that was not least expensive. It was global IBS treatments, right? Our FODMAP, our cognitive behavioral therapy, neuromodulators, those were less expensive than on-label prescription drug treatments. We find similarly in IBSD, patient perspective found that drug therapies and neuromodulators were preferable. And again, the reasons for that is they reduced their loss of wages. In other words, they could work more. They had more effective therapy, and also they did not have the out-of-pocket costs of the FODMAP, the low FODMAP diet, or the costs to attend cognitive behavioral therapy. Again, payer perspective is the on-label prescriptions, again, significantly more expensive than the off-label treatments, the low FODMAP diet or CBT. So you can see here where the patient perspectives are really the prescription drug therapies, and then the payer perspective is really kind of thinking about off-label treatments or FODMAP or cognitive behavioral therapy were preferential. When we look at the factors that kind of drive these assessments, you can see here the patient perspective is they want the costs for these therapies, the cost to buy the food, the cost to even take time off work or attend cognitive behavioral, those factored in very heavily into the patient's perspective, where the payer perspective really focused on the prescription drug costs. So again, very much explains why the preferences were what they were when we look at the different perspectives. So the other thing to think about is a study was done to look at coverage restrictions from a payer perspective, and they found that while covering the therapies is, preferential for the patient, payers found kind of a microsimulation was done, and that if they basically required the use of global IBS treatments before FDA-approved therapies, they did have per patient cost savings, about $9,000 for IBS diarrhea and about $2,900 for IBS-C over 1 year. So they found the health outcomes were similar regardless of treatment sequence. A couple of things with the IBS diarrhea algorithm was rifaximin was the most cost saving. With the IBS-C algorithm, linaclotide was the most cost-effective and cost-saving. But again, this study just showed that kind of delaying access to those treatments is cost-effective from a payer perspective. But I think this is also where shared decision-making comes in as well, to think about some of these other therapies and the patient's interest in those therapies. So to conclude kind of and summarize our strategies, facilitating an early diagnosis, I think, is crucial. And again, the GI communities are looking into ways to safely do that and to ensure kind of an appropriate diagnosis with the patient not having kind of cautionary or warning signs. Another strategy that's used is enhancing patient-provider communication, addressing the patient's concerns, employing shared decision-making. We talked about addressing the physical and mental health aspects of the patient. The other thing that I think we need to also focus on is monitoring outcomes. So in other words, it's one thing to provide access to medication, but if patients aren't getting the intended benefit or aren't getting the benefits or meeting their goals of therapy, I think we really need to think about, continuing therapy or adjusting therapy to try to meet those patients' goals of therapy. And then lastly, to ensure medication access, especially when we talk about perspectives that are going to enable that patient to work and to not have out-of-pocket costs if that's their preference. So with that, I'd like to conclude the presentation. And then we'll now open it up to hear your questions, and Dr. Cash will join us. All right, Dr. Cash, why don't we, let's see what questions have come in the chat box. It actually looks like we've got several here. Let's start with this one. It's about diet. It says, what's the best diet and what works in terms of getting patients to adhere?
That's a great question. So, diet, patients with irritable bowel syndrome, somewhere between about 50 to 60% of them will actually ascribe some of their symptoms, sometimes the entirety of their symptoms, to diet. And that includes diarrhea, bloating especially, sometimes even constipation, but it's really usually more on the diet or on the diarrhea and the bloating side. Now, there have been a number of diets that have been investigated. The most popular diet, and the one right now that has the best evidence to support its use, is the low FODMAP diet. And that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Basically, poorly digested fibers, carbohydrates, fructans, which are kind of sugars. Those seem to be the main offenders when you look at the constituents of this diet. But it's dairy, it's breads, it's grains, a lot of the vegetables and fruits that we eat. So that diet is quite restrictive. There's a lot of misunderstanding with regards to that diet. It is not meant to be a permanent diet. The best way to administer a low FODMAP diet, and I primarily do this in patients with bloating and more of a diarrheal component, either IBS that alternates between diarrhea and constipation, or IBS with diarrhea. There's not as much evidence for patients with constipation. But I utilize one of our skilled and trained GI dietitians, which we're lucky enough to have. But any really good dietitian should be familiar with this. And what they'll do is they will educate the patient and follow up the patient. Patient does a restrictive diet where they knock out all the FODMAPs that they possibly can for a few weeks, and then they start to gradually reintroduce them, assuming that they have a symptom response. If they have no symptom response with that restrictive diet, then you can just forget it and move on. But it's a gradual reintroduction of certain types of foods. If patients get symptoms, then they go backwards and restrict that again. So that's the best way. It's not meant to be a permanent diet. The other important thing with regards to dietary therapy for these patients especially is we need to do a better job of screening for avoidant and restrictive food intake disorder. That's the politically correct term now that we use for eating disorders, because we can engender that. There's some data that shows that upwards of 60 to 70% of people who were placed on low FODMAPs or restricted diets, gluten-free diets, for instance, are very popular in patients who don't have celiac disease. That ends up happening in patients who have a high predilection for avoidant restricted food. So we don't know whether we're reinforcing that or whether we're actually engendering that, but we need to do a good job of screening for that. And we really don't. And that's where our dietitians can really help us.
No, I think that's very helpful to do that. And it sounds like trying to figure out if that is even an option for patients, right? Like if you restrict food and you're not getting dramatic improvement, right? That may not be the strategy there. Here's a question about length of treating someone with medication. So I know sometimes with the plans, there's PA criteria, and then you have to, get an initial, and sometimes you get a year and then 12 months. But then the question is, how long can we treat someone with these medications?
Yeah, there's really, for all of the medications that we touched on, there's really no set limit. And there actually is now some good long-term data. Now, long-term in terms of a pharmacology study is typically a year in irritable bowel syndrome, looking at mostly safety, but also continued efficacy. I think it's important to remember that most of these therapies are non-absorbed. They're working locally within the GI tract, opening up channels or perhaps closing channels in some cases. So they can't, or binding channels and slowing down motility. So these medicines can be used long-term. Now, rifaximin is a little bit different, and that's a short-term therapy. It's kind of a paradigm shift. Short-term therapy and then repeat treatment if needed. But most of the therapies that we went over can be used, actually all of them can be used long-term. Of course, we recommend periodic reevaluation. I have lots of patients who ask, can I stop this? Well, how long do I have to take this? What I usually do in my clinical practice, I have no data to support this, but I'm sensitive to this topic, is to try to bargain with them. If we've got a therapy that's effective, then I will try to convince them to let me treat them for 6 months with that therapy, and then we can stop it. And if their symptoms come back, well, we already know what we can go back to that was effective, but we may be able to get them off, a medicine, decrease polypharmacy and increase compliance and, save that for somebody else who might need it. So that's my general take on this. But if they have recurrent symptoms, and some patients do require chronic therapy with these medications, and they can be really life-changing in a positive way for them when they work.
Well, and I think it's interesting because I do think, like I said, when you do have great effectiveness, right? It's interesting, are those the patients that are wanting to get off the therapy, or do you know what I mean? Or is it just a person that doesn't like to take medicines, right? Because I feel like you get such good relief, you wouldn't want to get rid of that therapy. But
yeah, it's a combination of both in terms of my practice. But I agree with you. I generally, the patients who have, they will come in and say, I have no life. And if you get them, especially thinking about the ones with diarrhea, but also constipation to some degree, if you get them better,
yes,
and they have a life, then they're usually more than content just to continue medicine forever.
Yeah. Yeah. Here's another question kind of on a different topic about, or actually it looks like, let's just go back because it's, I think, related to the foods. It said, what food should be avoided in IBS-C?
Yeah. There's not a lot of foods that have been linked to constipation. So, the ones that we generally recommend, and this is primarily what I've learned from my dietitians, is the high fatty foods, and although that can cause diarrhea as well, but that also slows GI motility to some degree. And then most of the time it's related more to bloating than it is constipation, and that's going to be the high FODMAP foods, the cruciferous vegetables, the foods that get highly metabolized or fermented by the microbiome often. But it's a much lower or shorter list for constipation than it is diarrhea. Diarrhea, there's lots of foods, but there's no specific foods that I would strongly recommend avoiding in patients with IBS-C, unless it was for symptoms such as bloating, and then it's generally the poorly digested or high fiber types of foods.
Got it. Great. So here's another question kind of on a different topic. It's about mental health. And it said, should patients' mental health be treated before using GI therapies?
Yeah. I view that as a very, I view mental health therapy as a very adjunctive therapy. So I don't think there's necessarily a set order. If they see a gastroenterologist, then what we're typically going to do, many of us are going to do, is to treat their IBS symptoms and ignore their mental health issues. And I think that's a very big missed opportunity. So I will generally do both. If I pick up that a patient's highly anxious or clearly depressed, and I think they really need a mental health specialist, then I will refer them to a psychologist or even a psychiatrist. I'm very comfortable using antidepressant therapies such as TCAs and SNRIs because I use those as neuromodulators. Now, I don't use SRIs to a significant degree in patients with irritable bowel syndrome because they've not been shown to be terribly helpful. They don't seem to improve abdominal pain, and patients who have more diarrhea or urgency, it can worsen that. So I tend to use low-dose tricyclics for pain, and then I use SNRIs for pain as well as sometimes anxiety or depression in those patients. But I also have a very low threshold to avail myself of the patient of a psychologist or psychiatrist. I think that's a really important part of treating them.
Yeah, kind of care coordination for the, all the aspects. And even you mentioned the dietitian as well earlier. So we're at the top of the hour. And so this has been great. I've learned a lot from you as well. And I'd like to thank our audience for joining us today.